Welcome back to the Deep Dive. Today we are really getting into the weeds on nephrology and urology.
We certainly are.
And for you, our listener, especially if you're a medical student just trying to get your head around all this, the functional anatomy, the disease syndromes, the management plans, well, this is our mission.
That's right.
We want to give you that definitive, structured overview. We're going to pull out the core concepts, the non-negotiable anchors that you just have to know.
That's absolutely the goal. I mean, the renal system is one of medicine's great multitaskers. It's functionally so complex.
It really is.
You've got excretion, fluid balance, hormones, acid base. The sheer amount of information can feel, well, overwhelming. So we're drawing on core knowledge to synthesize the key criteria, the essential why behind it all.
And the management priorities you need to master. And I think it all starts with just resetting our whole view of the kidney. It's not just a trash compactor. I mean, of course, it handles waste products, urea, creatinine.
Yeah.
But the bigger picture, it's a critical, multifunctional endocrine factory.
It absolutely is. It's managing acid-base balance down to the mill equivalent. It's the primary regulator of blood pressure.
And its role in bone health with vitamin D activation and in making red blood cells with erythropoietin.
So when we talk about kidney failure, we're not just talking about waste buildup. We are talking about systemic collapse.
Right.
It's a loss of bone strength. It's chronic anemia. It's uncontrolled hypertension. And sometimes, it's metabolic acidosis so severe it threatens every vital organ. Understanding the structure is the foundation.
Okay, so here's the plan. We'll structure this deep dive by location. We'll look at the filter itself, the glomerulus and the syndromes that come from its failure.
Those are big ones.
Then we'll move to the pipes, the tubules, and the interstitium, and talk about inherited and acquired defects there. We'll cover the urgent crisis, acute kidney injury,
AKI,
the long-term slide of chronic kidney disease, and finally, all the downstream urological issues. The plumbing, so to speak.
Good plan.
So let's start right where the action is. The incredible efficiency of the nephron.
Let's do it.
The numbers, when you actually stop and look at them, are just staggering. We often just glide past them in textbooks, but think about this. The kidney filters approximately 180 liters of plasma every single day.
180. That's enough to fill a full-size bathtub.
It's an industrial scale operation.
It is. But the real genius, the truly clever part, is what happens after that initial filtration.
The reabsorption.
The vast majority of that fluid, we're talking 178, maybe 179 liters, is selectively reabsorbed all along the nephron. The tubules, the loops, the collecting ducts, they're working constantly to pull back electrolytes, glucose, water.
All the good stuff.
All the good stuff, leaving us with just 1 to 2 liters of concentrated urine. It's an efficiency system running at absolute maximum capacity.
And the gatekeeper for that whole process, the very first step, is the glomerulus.
Right. And we use a definitive metaphor here. We have to. Think of the glomerulus as a highly selective coffee filter or a sieve. And to understand the pathology, you have to understand the 3 layers of this sieve. First, you have the capillary endothelial cells. They're perforated with little pores called fenestrae.
So they let the liquid and small solutes through.
Exactly. Then underneath that, you have the thick glomerular basement membrane, the GBM. That's the main structural scaffold.
That's support structure.
And finally, and this is maybe the most important part, you have the podocytes. These are visceral epithelial cells with these long, they're called foot processes that interdigitate like fingers.
And they form the slit diaphragms.
They do. And those diaphragms are the final fine-tuned selective barrier.
So this perfect sieve, what does it normally let through and what does it block?
It comes down to 2 fundamental properties, size and electrical charge.
Okay.
Size-wise, molecules smaller than about 20 kilodaltons, they're freely filtered, no problem. But anything bigger, like a massive red blood cell or even large proteins, should be blocked.
Like albumin. Albumin is the classic one, right? It's about 67 kilodalt.
Exactly. Albumin is definitely in that blocked category. But here's the really critical detail. For a protein like albumin, charge matters even more than size.
How so?
The GBM and the podocytes, they both carry a negative charge. And since albumin is also negatively charged at a normal physiological pH...
Like charges repel.
Precisely. That electrostatic repulsion is the primary mechanism that blocks its passage. Even if the pores could physically accommodate a tiny bit of it, the charge barrier stops it cold.
So if a disease, let's say minimal change disease, messes with that negative charge, even if it doesn't tear huge holes in the filter.
That's it. You immediately start leaking massive amounts of negatively charged protein, specifically albumin.
That's a fantastic anchor.
It's often called selective proteinuria if it's just the charge barrier that fails. But in many of the big glomerular diseases, both the size and the charge barriers are compromised.
Okay, so that whole filtration process needs constant pressure to work.
Right.
It doesn't matter if we're sleeping or stressed or running a marathon. How does this little organ keep its internal pressure so stable?
That's the absolute brilliance of autoregulation. You can think of it as the kidney's internal thermostat.
A thermostat, I like that.
Its whole goal is to keep the glomerular filtration rate, the GFR, constant. So if your systemic blood pressure dips, the kidney immediately alters the muscle tone in the afferent arteriole.
The vessel coming in.
And the acurent arteriole.
The vessel going out.
Exactly.
And the main tool it uses for this, especially when systemic pressure drops, has to be the renin-angiotensin-aldosterone system, or RAAS.
The RAAS system is the kidney's absolute first line of defense against hypoperfusion. Renin gets released from the juxtaglomerular cells when the kidney senses low pressure or sympathetic stimulation, or even low sodium delivery to the macula densa in the distal tubule.
And that cascade ends with angiotensin II.
Correct. And angiotensin II immediately does two things. Globally, it causes systemic vasoconstriction to raise your overall blood pressure. But locally, and this is the key, it preferentially constricts the efferent arteriole.
The exit pipe.
The exit pipe.
This is the anchor. This is the thing we have to remember. If angiotensin II preferentially tightens that exit pipe, pressure has to build up upstream, inside the glomerulus.
It's a temporary genius move to maintain GFR when the inflow pressure is low. The kidney is trying to buy time to maintain filtration until systemic perfusion gets restored.
But it's a fragile mechanism.
Extremely fragile. If you block that efferent vasoconstriction with certain drugs, or if the systemic pressure just drops too low for too long, that temporary fix fails and the GFR just collapses. This is absolutely crucial for understanding acute kidney injury.
Right. Okay, before we dive into the diseases, let's talk about the clinical examination.
Yeah.
So many renal diseases they're just silent early on. How do we spot the signs of trouble?
Well, you're right. Often the first clue is an incidental finding. Routine blood showing a high creatinine or a human dipstick that flags up protein or blood.
But physical exam can be really informative in advanced failure in uremia.
Deeply informative. You have to look at the skin first. Uremia can cause this characteristic sallow, sort of yellow complexion. Patients might have bruising because of platelet dysfunction, and they often have severe pruritus itching, which leads to excoriation marks all over.
And of course, you have to assess fluid and volume status. That's just fundamental.
Absolutely. Advanced kidney failure means fluid retention. So checking the jugular venous pressure, it's often elevated, and looking for sacral or ankle edema is vital.
And conversely, you can have depletion.
Right. Some tubular diseases or acute illnesses can lead to volume depletion, so you have to check for reduced skin turgor. And one more thing. You must look at the fundus of the eye.
For hypertensive changes.
Yes. Renal disease is inextricably linked with hypertension. And advanced or malignant hypertension can leave visible signs retinal hemorrhages, exudates on fundoscopy.
So the ultimate investigative anchor then has to be the glomerular filtration rate itself, the GFR. What's the gold standard and what do we actually use day to day?
The reference value for GFR is typically around 150 plus or minus 25 mLs per minute per 1.73 meters squared. The gold standard involves using exogenous markers, but that's not practical.
No.
So routinely we rely on the estimated GFR or eGFR. It's calculated from serum creatinine using equations like MDRD or CKD-EPI.
And creatinine is a cheap, reliable biomarker, but, and this is a big but, relying on eGFR has some major pitfalls that students must never, ever forget.
Yes, let's go through them.
Okay, so why is it an estimate and when is it just plain wrong?
Firstly, eGFR is exactly that, an estimate. The calculated number has wide confidence intervals. Typically, only about 90% of patients will have an estimate that's within 30% of their true GFR.
There's a lot of wiggle room.
A lot. Secondly, and this is perhaps the most critical point in an acute setting, it is completely invalid in acute kidney injury. The equations assume a steady state, a steady production and excretion of creatinine. It's impossible when renal function is changing rapidly day by day or even hour by hour. It's also not validated for use in pregnancy or in kids under 18.
And the muscle mass effect, we have to remember that.
Yes, absolutely. Creatinine is a breakdown product of muscle creatine. So if a patient is cachexic, severely ill, and amputee, they have very low muscle mass, they'll produce very little creatinine.
So a low serum creatinine in that person might fool the eGFR calculation in thinking their kidney function is better than it actually is.
It will overestimate their true function. And the opposite is also true. A very muscular athlete taking creatine supplements will have a high serum creatinine, making the eGFR underestimate their true function.
Wow.
And even some drugs like the antibiotic trimethoprim can block the tubular secretion of creatinine. It artificially inflates the serum level without any true kidney damage. You simply must interpret eGFR in the context of the patient in front of you.
Okay, let's pause there and unpack that. This is such a dynamic system. We just learned about the key mechanism for keeping that filtration pressure up.
You did.
So a quick check-in for you, the listener. Let's imagine you're managing a patient with underlying CKD who has developed a severe diarrheal illness. Their blood pressure's dropping.
The classic scenario.
Now, if their physician were to prescribe an ACE inhibitor, a drug that blocks angiotensin II at this exact moment, what dangerous thing would happen to their intraglomerular pressure, and what immediate detrimental effect would that have on their GFR?
And the answer lies right in that efferent arteriole we were talking about. Blocking angiotensin II just removes that essential vasoconstriction of the exit pipe.
So pressure just collapses.
Leading to an immediate, profound drop in filtration. It's a dangerous textbook case of acute, drug-induced pre-renal failure.
And if you struggled with that, please rewind and re-listen to that RAAS autoregulation discussion. It is a concept that saves lives.
It really is.
Okay, so let's get into the glomerular syndromes.
Right. And understanding these it's made so much simpler by recognizing the two major clinical syndromes they cause. Glomerular diseases are the root cause for a huge portion of end-stage renal disease.
And we can distinguish them by asking a simple question.
Is the filter merely leaky, which is nephrotic, or is it inflamed and actively rupturing, which is nephritic?
Let's start with that leaky subnephrotic syndrome. This is all about massive pathological protein loss.
Exactly. Nephrotic syndrome is defined by massive, non-selective proteinuria. This means that fine-tuning of the podocyte and the charge barrier is just gone. And the four cardinal clinical features, the tetrad, they define the syndrome, and they're all downstream effects of that catastrophic protein loss.
Okay, let's run through that tetrad. What's number one?
First, overt proteinuria. We define that as protein excretion greater than 3.5 grams in 24 hours.
A huge amount.
A huge amount. Second, because of that, you get hypoalbuminemia. Serum albumin drops below 30 grams per liter because the kidney is losing it faster than the liver can make it.
Okay, number three.
Third is generalized edema. Significant pitting edema. This is due to two things. One, the reduced oncotic pressure from the low albumin, and two, secondary sodium and water retention. The RAAS system kicks in because it thinks the intravascular volume is low.
And the fourth feature?
Fourth is hypercholesterolemia. This is a kind of non-specific response by the liver to the general metabolic chaos, and it just ramps up lipoprotein synthesis.
The consequences of this massive protein loss, are arguably more dangerous than the kidney failure itself at that point. This is what we call the high-risk state.
Absolutely. If the patient is hypercoagulable, they are prone to venous thromboembolism, including things like renal vein thrombosis. This is a critical anchor.
And why is that?
Because they're losing essential coagulation inhibitors in their urine, things like antithrombin III and protein C and S. At the same time, the liver is making more procoagulant factors. The whole balance shifts dangerously toward clotting.
And the second major risk is infection.
Yes. The infection risk is very high due to hypogammaglobulinemia. They're losing their immunoglobulins, specifically IgG, in the urine.
Which compromises their immunity.
It compromises their humoral immunity, making them really vulnerable to encapsulated bacteria like pneumococcus. So prevention, like getting the right vaccinations, is key.
Okay, let's look at the key diseases that cause this nephrotic picture. These are typically defined by injury focused on the podocytes with very little inflammation.
Right. So start with minimal change disease, or MCD. As the name suggests, the glomeruli look essentially normal under a light microscope. The pathology is entirely at the level of the podocytes.
What happens to them?
They lose their foot processes, we call it effacement, and they lose their negative charge. This is the most common cause of nephrotic syndrome in children, and critically, it usually responds very rapidly and completely to high-dose glucocorticoids.
So you can often treat empirically in kids without even needing a biopsy.
In a typical case, yes. That strong, reliable response is key.
Okay, the next major cause, Focal segmental glomerulosclerosis, FSGS. That sounds a lot more aggressive.
It is. FSGS is defined by scarring sclerosis. That's limited to certain areas or segments of only some glomeruli, hence focal. The underlying causes are really diverse.
It's a pattern of injury, not one single disease.
Exactly. It can be primary, where we think there's some unknown circulating factor causing the damage. Or it can be secondary to massive stress on the kidney, like from morbid obesity, chronic hypertension, or HIV infection.
And there's a really important genetic component here that's tied to ethnicity.
Precisely. There's a high carriage rate of specific APOL1 gene variants, which is prevalent in populations of West African descent. This is strongly associated with an increased risk and often a much more aggressive, treatment-resistant form of FSGS.
And that's clinically crucial.
It is, because primary FSGS is much less responsive to steroids than MCD, and it frequently progresses rapidly to end-stage renal disease.
And finally, the most common cause in those of European descent, membranous nephropathy.
Membranous, or MN, is different again. It's primarily an autoimmune disease. In the vast majority of cases, it's caused by autoantibodies.
Targeting what?
Often targeting the M-type phospholipase A2 receptor, or anti-PLA2R, which sits right on the podocyte surface. The immune complexes that form there cause this characteristic diffuse thickening of the glomerular basement membrane that we see on histology. And that chronic injury leads to a slow, relentless proteinuria.
Okay, so now we swing to the complete other side of the spectrum, the nephritic syndrome. The barrier isn't just leaky anymore, it's actively inflamed and breaking apart.
That's a great way to put it. If the nephrotic kidney is a sieve with big, clean holes, the nephritic kidney is a system where the internal pipes are ruptured and bleeding because of acute inflammation.
We're talking active destruction of GBM.
Yes, by immune cells and mediators.
Wow.
And that allows both red blood cells and inflammatory components to just pour into the urine.
So what are the immediate clinical features that anchor this diagnosis?
This often presents as rapidly progressive glomerulonephritis, RPGN, which is a true medical emergency because of the rapid loss of kidney function. The triad of features are, first, hematuria.
That's the hallmark.
The non-negotiable hallmark. It might not be visible, but on microscopy you see what we call the active urinary sediment, dysmorphic red cells.
Mangled from being squeezed through the damaged filter.
Exactly. And the highly specific diagnostic red cell casts. These are red cells molded into the shape of the tubule. Second is hypertension and fluid retention. The inflamed kidney just can't handle sodium and water. And third is a rapid decline in renal function, with creatinine just soaring over days or weeks.
And if you did a biopsy in this emergency setting, what would you see?
The hallmark histology of RPGN is the presence of crescentic lesions. These crescents are formed by the proliferation of cells lining Bowman's capsule, and it's a reaction to the severe inflammation and necrosis inside the glomerulus.
Okay, let's run through the three classic causes of this inflammatory picture.
First, post-infectious glomerulonephritis, or PIGN. This typically happens in children or young adults, and it presents about 10 days after a strep infection, like pharyngitis or impetigo.
The latency period is the key there.
It is. The kidney damage follows the infection. Serology will often show high anti-streptolysin O, or ASO, titers. The prognosis is generally very good with supportive management.
Okay, number two is the devastating anti-GBM disease, or good pastures.
This is a life-threatening autoimmune disorder. The autoantibodies specifically target the alpha-3 chain of type IV collagen.
Which is the backbone of the GBM.
Exactly. And crucially, that same collagen isoform is also found in the basement membranes of the lung alveoli. So you get this classic pulmonary renal syndrome with RPGN and often severe life-threatening lung hemorrhage.
And the treatment has to be aggressive.
Urgent. Plasma exchange to remove the antibodies, combined with high-dose immunosuppression.
And finally, the most common glomerulonephritis globally, IgA nephropathy.
IgA nephropathy is unique because of its timing. It presents with visible hematuria, often recurrently, that happens almost concurrently with a minor respiratory or GI infection. A very short latency.
So not like the 10-day lag in post-strep.
Not at all. It's thought to be caused by aberrantly glycosylated IgA depositing in the mesangium, creating this mild inflammation. And while it can present acutely, the typical course is a slow, progressive decline in renal function over decades.
Okay, let's pause again. We have to make sure we've got this distinction nailed down. It is foundational.
It really is.
So another quick check-in for you, our listener. A 6-year-old child presents with periorbital and severe dependent edema. Their measured serum albumin is 18 GL. Their history includes a recent positive ASO test. Which major syndrome is driving the edema, and which specific piece of clinical information suggests a potentially different diagnosis that needs to be considered?
Well, the severe edema and that massive hypoalbuminemia just scream nephrotic syndrome, leaky sieve. However, that high ASO test suggests a preceding strep infection. And that's the anchor for post-infectious glomerulonephritis, which is a classic nephritic syndrome.
So you have a conflict.
You do. So despite the overwhelming nephrotic features, you must urgently look for any signs of an active sediment dysmorphic, cells, casts, hypertension that would point towards a mixed or concurrent nephritic picture. And that completely changes the urgency and the management.
So understanding that two very different pathologies can be driven by a common antecedent infection is essential.
Absolutely essential.
Okay, we've spent a lot of time on the filter. Let's move beyond the glomerulus. The tubules and the supporting interstitium, they're responsible for that incredible 180-liter reabsorption process.
Exactly. So when these structures are damaged, you see different kinds of problems. Often problems with concentration, salt wasting, acidosis, rather than just massive protein loss. These are the tubulo-interstitial diseases.
Let's start with the acute one, acute interstitial nephritis, or AI. This is the classic hypersensitivity reaction in the kidney.
That's right. The mechanism is a delayed type IV hypersensitivity reaction, causing this acute inflammation of the interstitium. And the single most common cause is drug-induced.
What are the main culprits?
Surprisingly common drugs. Proton pump inhibitors, PPIs are a big one, NSAIDs, and several antibiotics, especially penicillins. It usually appears days or weeks after starting a new medication.
And what should raise our suspicion clinically? What does it look like?
It typically presents as an acute kidney injury, but often, and this is a bit of a paradox, it's non-olivuric. They're still making urine. In about a third of cases, you might see the classic systemic signs of a drug hypersensitivity.
Fever.
Fever, a generalized rash, and critically, eosinophilia in the blood.
Now, eosinophilia is often taught as the definitive anchor, but it's not always there, is it?
No, and that is a key learning point. It only occurs in maybe 20 to 30% of cases. Its absence does not rule out AIM.
So what else do you look for?
The urinalysis often shows sterile leukocyturia and sometimes white cell casts, which points to tubular inflammation. But the proteinuria is usually modest. And because the presentation is so nonspecific, the definitive diagnosis often requires a renal biopsy. Management is all about withdrawing the causative drug.
Okay, what about chronic damage? Chronic interstitial nephritis or CIN?
CIN presents with signs of CKD, but often with polyuria and nocturia. That's a sign the tubules have lost their ability to concentrate urine. They can also develop a severe salt-losing nephropathy, where they just continuously waste sodium.
Which puts them at high risk of volume depletion.
And hypotension, yes. Historical causes were things like long-term analgesic abuse, which is now rare, and chronic reflux nephropathy.
And papillary necrosis is a sort of ischemic catastrophe within the kidney.
It is. It's the localized death of the renal papillae, usually from chronic vascular compromise. It's strongly associated with poorly controlled diabetes, sickle cell disease, chronic obstruction. The danger is when those necrotic papillae slough off.
They can act like a stone.
Exactly. They can cause acute ureteric obstruction and severe renal colic.
Okay, let's move into the inherited conditions, which teach us so much about the genetics of all this. Let's start with the classic basement membrane defect, Alport syndrome.
The anchor for Alport syndrome is its genetic basis. It's usually X-linked mutations in the COL4A5 gene, which encodes a specific component of type 5e collagen.
And that's the collagen that makes up the GBM.
Right, so the GBM progressively degenerates, but the key to the diagnosis is often the extrarenal features.
Because that collagen is found elsewhere.
Yes. So Alport syndrome involves a classic triad: progressive renal failure, accompanied by sensorineural deafness from cochlear involvement and specific ocular abnormalities like anterior lenticonus.
Okay, next up, the most common inherited kidney disease, autosomal dominant polycystic kidney disease, ADPKD. This isn't just a kidney problem.
No, ADPKD is a truly multi-system disorder. It affects about 1 in 1,000 people. Cysts form and enlarge in the tubules, and they just progressively compress and destroy the normal kidney tissue.
And there are two main genes.
Two key genes. PKD1 accounts for about 80% of cases and leads to earlier progression, with end-stage renal disease, typically around age 50. PKD2 mutations are less severe.
Beyond the huge, palpable kidneys, what are the crucial associated features we have to screen for?
These are vital because of the risk of sudden catastrophic events. Most patients develop liver cysts, which can become massive. But the critical life-threatening complication is the presence of baryaneurysms in the cerebral vessels.
Which can rupture and cause a subarachnoid hemorrhage.
Exactly. So that requires regular screening in high-risk families. They also commonly develop valvular heart disease and colonic diverticula.
And management has become more specific recently.
It has. Tight blood pressure control is still paramount. But the big therapeutic advance is tolvaptan. It's a vasopressin V2 receptor antagonist.
How does that help?
Well, vasopressin promotes fluid accumulation and cyst growth. Tolvaptan blocks this, slowing the increase in kidney volume and the rate of GFR decline in high-risk patients.
Let's quickly contrast two fascinating pubular defects, Fanconi syndrome and Bartter-Gittleman.
These are marvelous teachers of physiology. Fanconi syndrome is a generalized failure of the proximal tubule.
Which is responsible for bulk reabsorption.
Exactly. So failure leads to classic wastage. Low plasma phosphate, low urate, glycosuria, aminoaciduria, even when blood glucose is totally normal.
And Bartter and Gittleman syndromes, they often mimic diuretic use.
Precisely. Bartter syndrome mimics chronic use of a loop diuretic because it involves mutations in the NAK2Cl transporter. Gittleman syndrome mimics chronic use of a thiazide affecting the NaCl transporter. Both result in sodium wasting and hypokalemia, but knowing the specific transporter tells you exactly where the physiological defect lies.
Okay, let's shift gears. From the slow course of chronic disease to the urgent dynamic crisis of acute kidney injury, or AKI.
Right. AKI is a sudden loss of function over days or weeks, signaled by a rise in creatinine or a drop in urine output. And when it's associated with something like sepsis, the mortality rate is tragically high, 50 to 70%.
For the student at the bedside, that three-part classification is just the most powerful tool, the inflow, filter, outflow anchor. It categorizes and guides your immediate actions.
It does.
So let's start with the most common and most reversible form, pre-renal AKI, the impaired inflow.
Prerenal failure is a functional problem. The kidney structure is still intact, but it's just starving of blood flow.
So what causes that?
The causes are volume depletion, hemorrhage, severe vomiting or diarrhea, poor cardiac output from heart failure, or widespread vasodilation like in sepsis or anaphylaxis.
And this is where the medication discussion from earlier comes right back in.
It does. We talked about that life-saving mechanism of angiotensin II constricting the efferent arteriole. Well, drugs like NSAIDs, which block afferent vasodilation, or ACE inhibitors and ARBs, which block efferent vasoconstriction, they strip the kidney of its autoregulatory safety net.
Making it acutely vulnerable.
Exactly. Acutely vulnerable to even mild hypotension or dehydration.
And what are the key lab clues that tell you the kidney is still trying to conserve volume?
The kidney is acting appropriately. It's maximizing sodium and water reabsorption. So the urine is highly concentrated. The urine sodium is very low, typically less than 20 millimoles per liter. And the fractional excretion of sodium, the FeNA, is low, usually less than 1%. And the urinalysis is bland, no casts, no cells.
Okay, but if that pre-renal state goes on for too long, or if a toxin hits the kidney directly, the functional structures start to die. You transition to intrinsic renal AKI.
And the classic intrinsic kidney injury is acute tubular necrosis, or ATN, usually caused by ischemia, so prolonged shock or toxins like aminoglycosides, IV contrast, or rhabdomyolysis. And when those tubular cells die, they lose their ability to conserve anything.
Which completely changes the lab picture.
It completely reverses it. Because the tubules are necrotic, they can't reabsorb sodium, so the urine becomes dilute, the urine sodium becomes high, typically over 40, and the FeNA is now greater than 1%.
That's the anchor sign of ATN.
It is. And on microscopy, the pathognomonic sign is the shedding of those necrotic cells into the urine, which form the highly characteristic granular, muddy brown casts.
And other intrinsic causes just reflect the pathology we've already discussed.
Exactly. If the intrinsic injury is a glomerulonephritis, you see red cell casts. If it's acute interstitial nephritis, you're looking for sterile pyuria and white cell casts.
Okay, finally, post-renal AKI, the purely mechanical outflow blockage.
This requires complete obstruction. And crucially, unless the patient only has one functioning kidney, the obstruction has to be bilateral to cause failure.
And the causes are usually at the bladder level or below.
Right. Benign prostatic hypertrophy, BPH, or cancer prostate, bladder, gynecological. The diagnostic anchor is simple and immediate. You look for hydronephrosis on a renal ultrasound, and that blockage has to be relieved immediately.
When you're managing any AKI, the immediate priorities are life-saving, and they often center on one specific electrolyte.
Hyperkalemia. It's the #1 immediate threat. If the serum potassium is over 6.5 or if there are ECG changes.
Peak T waves.
Peak T waves, broadened QRS, you have to act immediately. And the first drug you give is calcium gluconate. It does not lower potassium. It stabilizes the cardiac cell membranes, protecting the heart from a fatal arrhythmia while you wait for the potassium-shifting treatments to work.
And let's just reiterate that essential preventative teaching, the sick day rule.
The sick day rule card is essential primary prevention. Any patient on an ACEI, ARB, NSAID, or strong diuretic must be told to stop these medications during an acute illness. A fever, vomiting, bad diarrhea. They are stopping the drugs that impair the kidney's ability to protect itself during low perfusion.
Okay, let's reflect on that transition point, from a functional to a structural injury. It's where a lot of people get caught out.
It is.
So another check-in.
Yeah.
You have successfully resuscitated the patient after septic shock, but their creatinine stays high. You test their urine and find the fractional excretion of sodium, the FeVANA, is 3%, and the urine sediment is loaded with those granular, muddy brown casts. Given that FeNA, can you still call this pre-renal failure, and what was the precise sequence of events?
No, you absolutely cannot. The FeNA of 3% and those muddy brown casts confirm this is no longer pre-renal. It is now established intrinsic AKI, specifically acute tubular necrosis, ATN.
And the sequence.
The sequence was pre-renal failure due to the septic shock and poor perfusion, which led to prolonged renal ischemia, which then caused widespread necrosis of the tubular cells. That's ATN. The necrotic cells slough off as casts, and their functional failure is why they can no longer conserve sodium, leading to that high FeNA.
Perfect. Okay, let's move to the long-term slide. Chronic kidney disease, CKD. An irreversible deterioration over years with an eGFR below 60.
Right, and symptoms of uremia often don't truly emerge until that GFR is below 30. CKD is an epidemic, and it's primarily driven by long-term systemic diseases.
What are the top causes?
Consistently diabetes mellitus, followed by hypertension, and then a mix of glomerular and interstitial diseases. The goal in managing CKD is all about slowing that inevitable progression and managing all the systemic complications.
And what are the two non-negotiable pillars of CKD management? The things that must be addressed in every single patient.
The first pillar is aggressive blood pressure control. Tight targets, often less than 130/80, are vital. The second pillar is proteinuria reduction. This is essential because persistent proteinuria just accelerates the fibrosis and destruction of the kidney tissue.
And how do we achieve that?
Through the dedicated use of ACE inhibitors or angiotensin receptor blockers, ARBs. These drugs are prescribed to every patient with CKD who has significant proteinuria regardless of their baseline blood pressure.
And their protective mechanism goes right back to that autoregulation lesson.
It does. By reducing angiotensin II, they preferentially dilate the efferent arteriole. This lowers the high intraglomerular pressure and slows the damage to the remaining filtration barrier.
Now, since the kidney does so much more than just filter, its chronic failure leads to some profound metabolic and endocrine complications. Let's break down the big three.
Okay. First is renal osteodystrophy, the bone disease. The failing kidney can't fully activate vitamin D. This leads to poor calcium absorption and low serum calcium.
And the body compensates?
It does by ramping up parathyroid hormone, PTH. This is secondary hyperparathyroidism, and it pulls calcium from the bone, causing bone pain, fracture risk, and severe vascular calcification.
Okay, number two is the debilitating anemia of CKD.
This is primarily due to erythropoietin deficiency. Erythropoietin is normally made by cells in the renal cortex. As those cells are lost, production just plummets. This is made worse by iron deficiency and the uremic environment suppressing the bone marrow.
So you replace it.
We replace it with ESA therapy, but we have to make sure iron stores are replete first. And our hemoglobin target is modest, 100 to 120, to avoid the increased cardiovascular risk seen at higher levels.
And third, the acid-base imbalance.
Chronic metabolic acidosis is very common. The failing kidney just struggles to excrete its acid load, and we actively treat this with oral sodium bicarbonate supplements to try and keep the plasma bicarbonate concentration above 22.
So when function eventually drops to end-stage renal disease, CKD stage 5 renal replacement therapy, or RRT, is required. And this is a massive shift in a patient's life.
It is. RRT really encompasses 3 pathways. The decision depends on the patient, their lifestyle, comorbidities, and what's available.
Okay, pathway number 1, hemodialysis or HD.
HD requires an external circuit. Blood is pumped out of the body across a synthetic membrane, the dialyzer, and then returned. This needs robust vascular access, ideally an arteriovenous fistula, or AVF, created surgically months in advance.
And it's a big time commitment.
It is, usually 3 times a week for 3 to 5 hours in a hospital or unit. The downsides are that time commitment, the need for access, and the risk of rapid fluid shifts causing hypotension during treatment.
Pathway number 2 offers more autonomy, peritoneal dialysis, PD.
PD uses the patient's own peritoneal membrane as the filter. A high osmolarity fluid is infused into the peritoneal cavity via a catheter. This can be done by the patient throughout the day or automatically by a machine overnight.
What are the big risks there?
The major non-negotiable risk is peritonitis, infection of the peritoneal cavity. It presents with cloudy drainage fluid and abdominal pain. Repeated episodes damage the membrane and can force the patient to switch to HD.
And then there's the ultimate goal for suitable candidates.
Renal transplantation. This offers the best long-term survival and quality of life. The new kidney is placed in the pelvis. It requires lifelong immunosuppression, usually a triple therapy regimen to prevent rejection.
Okay, let's revisit that delicate balance when managing CKD with the protective RAAS inhibitors. This is a common exam question and a critical clinical decision.
Yes.
A patient with established CKD and heavy proteinuria is started on an ACE inhibitor. 10 days later, their eGFR has dropped from 35 to 28. Should the drug be stopped immediately?
No. That is a 20% drop, which is expected and acceptable. The drug should be continued, provided the reduction is less than 25% and it's non-progressive.
Why?
That initial drop actually confirms the drug is working. It's reducing that pathological hyperfiltration pressure. You only stop if the drop is profound, over 25%, or if the patient develops life-threatening hyperkalemia. That initial drop is the cost of long-term renal protection.
A fantastic point. Okay, we have thoroughly analyzed the nephron. Now let's look at the downstream system, the urinary tract plumbing. Starting with the most alarming symptom a patient can have, hematuria.
Visible or macroscopic, hematuria must always be treated as a red flag. It demands urgent, thorough investigation until you have ruled out malignancy.
And malignancy is a real risk.
A very real risk. The source material notes that malignancy bladder, kidney collecting system is found in about 14% of patients presenting this way.
So what's the non-negotiable investigative pathway?
After you've excluded an obvious cause like an infection, the patient has to be referred to urology. The workup has 2 key components: flexible cystoscopy to look inside the bladder, and upper tract imaging, usually a CT urogram, to visualize everything higher up.
And how do we use microscopy to differentiate a benign lower tract bleed from, say, a dangerous glomerular rupture?
This is a clinical gold standard. If the red cells are coming from the lower tract, the bladder prostate, they'll be uniform and intact. But if they're coming from the filter, they've been battered and squeezed through the damaged GBM, they will appear dysmorphic. And more importantly, the presence of red cell casts is pathognomonic of glomerular bleeding.
Okay, let's move to another major source of acute pain, urolithiasis, or kidney stones.
Right.
What are they made of, and what's the classic presentation?
The majority of stones are calcium oxalate, about 60%. We also have to mention struvite stones. These are associated with chronic infection and can grow to fill the entire renal pelvis, forming these large branched structures called staghorn calculi.
And the presentation.
The hallmark is renal colic. Sudden, severe, unbearable loin pain that radiates down the flank toward the groin. The patient is typically restless and distressed.
What's the rationale for the first-line pain management?
NSAIDs, like diclofenac, are best. The pain is caused not just by the blockage, but by inflammation and spasm. NSAIDs reduce that prostaglandin-mediated spasm, often providing better relief than opioids.
And when does a stone become a surgical emergency?
If the stone causes an obstruction, ND, there is evidence of infection proximal to it, a condition called pyonephrosis. It is an absolute surgical emergency. It requires urgent drainage to prevent life-threatening urosepsis.
And long-term prevention is all about lifestyle.
It is. The anchor advice is aggressive hydration. Aim for 2 liters of urine output per day. Low sodium intake and maintaining a normal, not low, calcium intake to bind oxalate in the gut.
Okay, let's talk about tumors of the urinary tract, starting with renal cell cancer, or RCC.
RCC is the most common kidney malignancy. Today, almost half are found incidentally on imaging because the classic triad of pain, mass, and hematuria is rare and usually only appears in very advanced disease.
And RCC is famous for its paraneoplastic syndromes.
It is. It's known as the Great Mimic. It can secrete various hormones, leading to systemic effects. unexplained fever, polycythemia from erythropoietin secretion, hypercalcemia.
How has the surgical approach evolved?
For localized RCC, the trend is now toward partial nephrectomy, removing only the tumor. This is crucial because preserving as much normal renal tissue as possible reduces the patient's long-term risk of developing CKD.
And what about urothelial tumors, which affect the bladder?
These tumors are strongly linked to environmental exposures, especially smoking. The cardinal symptom is almost always painless, visible hematuria. Management depends entirely on staging. If it's non-muscle invasive, it's treated endoscopically. If it's muscle invasive, it often requires a radical cystectomy.
Okay, let's finish with the common functional issues of the lower tract: prostate disease and incontinence.
Benign prostatic enlargement, BPE, is almost universal in older men. It causes lower urinary tract symptoms, or LUTS.
Things like hesitancy, weak stream, nocturia.
Exactly. The severity is quantified using the International Prostate Symptom Score, the IPSS.
And the medical treatment targets two distinct physiological mechanisms.
It does. First line are alpha blockers, like tamsulosin. They act quickly to relax the smooth muscle. If the prostate is significantly enlarged, we add 5 alpha reductase inhibitors, like finasteride, which physically shrink the prostate over several months.
And finally, a quick rundown on the types of urinary incontinence.
3 main types. Stress incontinence is leakage with physical effort, like coughing or sneezing. Urge incontinence is from involuntary detrusor muscle contractions, treated with bladder retraining and anticholinergic drugs.
And the most dangerous, overflow incontinence, which often results from that BPE we just talked about.
Right. Overflow is chronic overdistension. The bladder can't empty and just spills over. This causes high-pressure chronic retention, which backs up into the ureters and can cause AKI.
A crucial connection to make.
A very crucial connection.
That was a comprehensive tour. We started with the functional integrity of a single podocyte, and we ended with the anatomy of the urethra. We managed the acute crisis and the long-term slide.
And we really aimed to firmly anchor those critical learning points for you. Remember that dichotomy: nephrotic massive protein, hypercoagulable, infection risk versus nephritic inflammation, blood, hypertension, rapid decline.
And remember the physical anchors. Red cell casts mean glomerular bleeding. Muddy brown casts mean tubular necrosis.
And use that 3-part AKI classification instantly at the bedside: inflow, filter, and outflow.
And for chronic kidney disease, carry those 2 essential management pillars with you: tight blood pressure control and RAAS blockade for anyone with their proteinuria, accepting that initial eGFR drop as the necessary price for protection. So we'll leave you with one final, critical, provocative thought for reflection. It stems from the silent, relentless nature of kidney failure and its systemic impact. Given the kidney's crucial role in regulating calcium, fluid, and blood synthesis, and knowing that cardiovascular disease is the #1 killer of CKD patients, what is the single most important non-renal complication you must focus on aggressively managing in every patient with CKD stage 3 or higher, even if they never reached analysis?
And the answer is that the cardiovascular system is the ultimate victim of CKD. Left ventricular hypertrophy, accelerated atherosclerosis, chronic inflammation, they all drive massive cardiovascular mortality. Patients often die from a heart attack or a stroke many years before they would ever require dialysis. So managing lipids, blood pressure, volume, preventing vascular calcification, that is arguably the most important task of anyone managing a CKD patient. That holistic view, treating the heart as much as the kidney, is a definition of excellent chronic care.